Thank you for joining us for Take a Minute for Medicare. Robin Dawson of Medicare Solutions Network returns to address cost-saving strategies for the years ahead and what to think about as the annual enrollment approaches. Join us October 19th at 6:30 for the Chicago Black Renaissance, brought to you by a grant through Illinois Humanities. Presenter Amira Davis holds a PhD in Educational Policy Studies with a concentration in African American Studies from UIUC. So that should be a really interesting presentation. So please join us for that. And I know we had a few questions, but this program is being recorded, so I should have that recording out sometime tomorrow afternoon. So if there's something that you missed, you're able to go back. If you haven't already grabbed them, there's brochures up at the front. For those of you that are at home, we will be emailing some additional information too, along with the recording. So if you are in the room, if you could please silence your phones, that would be great. And if you are joining us from home, if you could put your questions in the chat at any time, we'll get to those at the end of the program.
All right.
Welcome. Thank you.
All right. Welcome, everybody. Thanks for coming out tonight. Thanks to the virtual audience for tuning in at home. As Jamie mentioned, my name is Robin Dawson. I'm an independent health insurance broker. Yes, I'm an insurance agent, but tonight is not a sales pitch. It's very educational. We're going to kind of take you from top to bottom in the Medicare system. We will talk about enrollment periods and all that jazz, but we're also going to focus on what you should be thinking about this time of year as the annual enrollment approaches. We continue to do these programs 12 months out of the year. This is all I do for a living. I don't work for the federal government. I don't work for Social Security. I don't work for Medicare, but I know a lot about those things, and I feel it's a service, and I commend the library for bringing us in to speak every year, because everybody, whether you're at the start of your Medicare journey, in the middle of it, or nearing the end, everybody feels like this, especially this time of year. I love the industry I work in. I do not particularly like the way they advertise to people, because I think it's very misleading and confusing. But the good news is that you're in the driver's seat. As a consumer, you have a lot of choice. We live in a very competitive market in Illinois, but sometimes I can appreciate it feels a little bit like standing in front of this long maze when it comes to choosing your coverage. A lot of people, our friends and family mean us well, right? We always ask for everyone's advice when we're about to embark upon a journey that they've maybe traveled prior to us. And I love this slide because I always hear people tell me multiple times a week, well, my friend said this, or this person told me this for sure, like I'm going to be penalized if I don't do this or that, or I need to get this plan because I heard it was the best. Listen, this is your time to think about things for you individually. You have different healthcare needs, different budgets, different lifestyles, different doctors, different medications, and everybody feels really passionate about the choices they make in Medicare, but you really need to think about this individually to you. So get the advice, bring it all in, soak it all in, ask all the questions you need to ask. But then when it comes to your decision-making process, really think about yourself. I can appreciate the fact that, people don't always want to sit down and talk to an insurance agent like me before they've done their research. So I commend you all for taking the time to do your research by coming to this program tonight. But I'm going to point out a couple of government resources that are really good resources of information. One of them is this Medicare New Book. I've got the 2024 image on the slide. If you're already in Medicare, you probably have already gotten this in the mail. They started mailing within the last week. I have to get my new copy. But this is the Bible of my industry. It's chock full of a lot of answers to basic questions that most people have when they start Medicare, okay? Enrollment periods, what do I do if I continue to work? How does coordination of coverage work? What is Part D? What am I going to be penalized if I hang on to that for my other coverage before I need to enroll in that? So it is a really good resource. It also covers some updates that the federal government will push out relative to new coverage options, like around vaccines. It'll talk about your basic coverage under Part A and B at a very high level, okay? My second favorite resource is the government website, medicare.gov. Please note the URL. This is not medicare.com. Up there in the left-hand corner, .gov, that's an indication that that's a government website. The Centers for Medicare and Medicaid is cms.gov. The Social Security Administration, where you're going to initially sign up for your Medicare Part A and B benefits, that's ssa.gov, okay? But this is a really good website. This Find Health and Drug Plans tab is where we'll go to help identify some plans for our clients initially. The site just changed over on October 1st because the annual enrollment is right around the corner. This is the time when people who are already in Medicare can change plans, okay? So if you're turning 65 and it just happens to overlap in this time period, whether you intend to come to Medicare or not, you have a different time frame. Similarly, if you're planning on retiring at the end of the year and coming off of employer group coverage and you're 68 or 69, different window, okay? This window doesn't apply to you. It's just for people already in Medicare who want to make changes to their plans, okay? This website is backed up by another good resource from the government. It's a phone number, 1-800-Medicare, and that phone number is staffed by people that can answer pretty much any question that you possibly might have about Medicare. It is open 24/7, almost 365 days a year. Okay. So if you are lying awake at night wondering if you should change your prescription drug plan, you can call 1-800-Medicare and those folks will be able to help you out. Or you can embark on this website and check down here, or you can give a broker or an agent a call, like if you worked with somebody in the past. Okay, so what is Medicare? It's the health insurance, U.S. health insurance program for seniors. A person 65 plus is deemed a senior. Now, there are certainly a population of insured that might come to Medicare early, okay? And if they're coming to Medicare at age 25 or 35, it's because they've been either declared disabled and they've been on disability benefits, collecting Social Security disability benefits for 24 months. On the 25th month, their red, white, and blue card will automatically show up in the mail. Okay, now they don't have to take those benefits if they don't want them, but they will be auto-enrolled on the 25th month of being on disability. Maybe they're not collecting disability benefits, but they have other significant health considerations in life. They have end-stage renal disease, Lou Gehrig's, things of that nature will also qualify someone for their Medicare benefits early, okay? But the most important thing on this slide that I want everybody to pay attention to is that original Medicare, really, really good coverage, okay? But it was never designed to cover everything. There are gaps in the coverage, things that you need to self-insure for through other insurance products, or copays and deductibles and coinsurance amounts that you're responsible to pay after Medicare pays their portion for even the covered things, okay? So we're going to talk about what Medicare does and doesn't cover tonight, very specifically. We're going to also talk about what the cost structure is for you under Medicare Part A and B in 2023. The 2024 amounts have not been announced yet. And we're going to talk about what your options are for coverage to minimize those out-of-pocket expenses. All right, this is the Medicare journey. This is where it begins. When you decide you are going to step off of your other qualified coverage and enroll in Medicare, you're going to get this red, white, and blue card. Now, you're going to go to the Social Security office to enroll in Medicare. If you don't want to go into the office or schedule a phone appointment, you can also now do it online, which is awesome, okay? You can go to ssa.gov and log in with your username and password. If you haven't already set up an online account, I encourage you to do that. You're not going to be able to access the Medicare online enrollment system until you've set up an online account at ssa.gov, okay? Now, if you're not planning, there's really two things we do at the Social Security office. That umbrella entity handles our Social Security retirement benefits, right? That's when we get less back than we paid into the system after working, decades in our life. And then there's also the Medicare benefits section, okay? And you don't have to do those at the same time. Some people do, okay? But the people that don't, they can go in and sign up for their Medicare benefits and they'll get billed by the Social Security office for those insurance premiums. But if you're already taking your Medicare benefits, and let's say you decided to take your retirement benefits early, you're not 65 yet, you'll be automatically enrolled in Medicare, okay? It'll start the first of the month in which you turn 65. Or maybe now, finally at retirement, you perhaps turned on Part A of Medicare at 65, and now you're going to add your B and come off of your employer-sponsored plan. You can do that as well through the Social Security office. You just have to show proof of creditable coverage. But everybody gets this 7-month window around their 65th birthday to sign up for Medicare or not, okay? 3 months before your birthday, the month of your birthday, and 3 months after, you can go in and put in your enrollment for A and or B. And if you go in 3 months ahead, your benefits will start the first of the month in which you turn 65. Doesn't matter if your birthday's on the 15th or the 25th. The only people who get to start 1 month ahead of their birthday month are the people whose birthdays land on the first of a month. Then they get pushed up a month. Okay. Everybody else is going to start the first of a month. Now, let's say life is just busy and you forget, or you wait till the month of your birthday or the 3 months after. That's fine. You still have that window to sign up for Medicare, no penalty, but your Part B benefit, the part that covers your medical coverage, that's going to be delayed by 1 month. Okay. So if you sign up in month 4, it's going to start the month after, first of the month after, and so on and so forth. Okay. So just know that if you're trying to time that around coming off of other qualified coverage. Now, what is creditable coverage in the eyes of the federal government that allows you to defer on Medicare without a penalty past this 65th birthday window? One type of coverage, employer-sponsored plans with an employer that has 20 or more people, and it's based on your or your spouse's active work status. All of those 3 things need to be true, okay? If you're on a retiree benefit, maybe you retired early, but your employer loved you, you worked there for 30 years, and so they gave you full coverage until age 65, you got to get on Medicare, okay? Because that's not based on active work status. Maybe you were downsized or right-sized or lost your job, but you're not quite Medicare age yet, okay? You can be on that COBRA benefit all the way up until age 65, but then at age 65, you need to get off of that. Okay. You do have 7 months upon loss of other creditable coverage, 8 months actually, to get to Medicare and sign up for Part B in particular without penalties. So it's not like if you lost your job tomorrow and you were 67 that they'd, start penalizing you the very next day. No, you have an 8-month window to get to Medicare. But you really, you don't want there to be gaps in coverage. So you might want to do that enrollment as soon as possible. Now, I mentioned before that some people sign up for Part A when they turn 65, but they'll defer on the B if they're still working. And that's because Part A for most Americans, has no premium. All right. You've paid for it your entire working life if you've worked at least 10 years or 40 working quarters. Or if you can avail yourself of your spouse's contributions into Social Security in their working years, you could have a 0 premium Part A. But let's say maybe you worked for the state or the city and you paid into a pension. You didn't pay into Social Security. Then you might owe something for Part A. And if you do, you have to turn it on when you turn 65. Okay. Part B has a monthly premium. This year, that premium is $164.90 per person per month. And that triggers when you turn on your Part B. Now, any part of Medicare is going to stand behind your employer insurance if you're going to continue to work and stay on that group plan. So turning on a 0 cost benefit, right, if you have enough tax contribution to Social Security, that can't necessarily hurt you, right? It'll just sit behind your group insurance as secondary for some certain things. But you really don't want to turn on the Part B until you're ready to step off of that coverage and retire. Otherwise, you're going to probably pay for something that you're not really going to use until you're off your group plan. All right. The other reason sometimes people defer on B is because it's means tested for income. So depending on what you're paying for your employer plan or what you're paying to keep your spouse covered on the plan as well, it might be equal to or less than what you might pay for Medicare. So when you go to apply for Medicare, just know, whether it's at age 65 or at some point in the future, the Social Security office is going to look at the most recent tax return they have on file for you. They're going to look at the modified adjusted gross number on that return. And if you fall into one of these higher brackets, the left-hand column is for individual filers, the middle column is for joint filers, you're going to pay more for Medicare, okay? So it goes up $65, then $164, then another $263, and so on and so forth, okay? So just like taxes, the more you make, the more the government requires that you pay. Now, if you get hit with your premiums on Part B with the income adjustment amount, it's also going to impact you on Part D, your prescription drug coverage. So you get hit with the income adjustment in 2 places. Now, you might say to me, well, Robin, that's not fair. I'm going to be retiring. I'm not going to be making that kind of money anymore when I go to Medicare. And I would say you're absolutely right. So when that letter shows up from the Social Security office after you've applied and they've looked at your return and they see that you're in a higher income bracket and they want to charge you more for Medicare, you can appeal that because retirement is considered a life-changing event. But just know that throughout your lifetime in Medicare, the Social Security office is going to look at this, your return, on a rolling 2-year basis. So every couple of years, they're going to do a redetermination. They're going to look at the most recent return they have on file for you. They're going to look at that modified adjusted gross number. And if you get a letter in the mail from Social Security that says you owe us more for Medicare, you're going to have to pay that higher amount until the next redetermination period, unless you have a qualifying event or a one-time taxable event that you can appeal. Okay? All right, let's keep moving. Different parts of Medicare. There's 4 different parts of Medicare. Part A and B form the foundation of your coverage. This is what you're going to sign up for through the Social Security office, either in person, online, or over the phone. Part A covers us for our hospital benefits, but it covers you actually for more than just hospital care. I would rename that our facilities charges because it covers you for a lot of the buildings you're going to kind of come in contact with at Medicare. Part B is our medical coverage. I would call that your services charges because anybody who provides a service is going to bill to Part B. All right. So that forms your foundation. Now, some people might decide that they want a private insurance company to run their federal benefits in Medicare. And you can choose that option if you want. At the start of your Medicare journey or anytime throughout your lifetime, you can choose a Medicare Advantage plan. Part C is what it's known by in Medicare. Now, Part C plans replace Medicare. You still have to pay your premiums for your Part B into Social Security. But what the government does if you sign up for a Part C plan is they're going to pass you over to a private insurance company and say, okay, you guys run Robin's benefits in Medicare. Here's her insurance premiums. Here's some federal tax dollars to support your administration cost of running her benefits, but you're going to take care of her. And you're going to give her all of her benefits under Part A, Part B, and in many cases, also give me my qualified Part D drug plan. Okay. But this is an option that many people choose in Medicare at some point in their life, or maybe not at all, or maybe at the beginning. It's up to you. Part D is simply your prescription drug coverage. And I don't want to minimize that. It is very important that you have Medicare Part D. And in fact, it's the only thing that Medicare requires that you get when you enroll in your A and your B. Okay. Now you can get a Part D plan just if you have Part A. So if for whatever reason, let's say your group insurance that you decided to stay on didn't have a qualified Part D drug plan in it, the drug coverage that was in it wasn't deemed equivalent to Medicare Part D, but in the eyes of the federal government. And your employer would let you know that as a 65 plus person on the plan. Most sponsored plans do have equivalent Part D drug coverage, but if yours didn't, you could pick up a standalone Part D drug plan if you needed to. But you definitely want one when you come to Medicare and you step off of whatever other qualified Part D drug coverage you have. Yes.
With Medicare Part C, since it's private, you're paying them then, correct?
Sometimes there's not a premium for those plans, but yes, you would be paying them something additional for the plan, and then there would be costs under the plan. Yeah, and we're going to break that down in detail tonight. But the important thing to know is that Part C plans don't sidestep your having to pay for Medicare. Okay, so the way to think about it is everybody pays for Medicare A and B. Okay, those two pieces have to be fired up for you to get a Part C plan. You're just asking a private insurance company to run your benefits in Medicare versus having the federal government do it. Okay. All right, this is the 10,000-foot view of Medicare. This is the first page of the handout that those in person have, and that the library is going to mail or email to those after the program. So I think Medicare is a pretty complicated topic. It's got a lot of moving parts, but I think visuals help. And I love this diagram because it's a good overview of the paths that a person can travel when they come to Medicare. Now, as I mentioned before, your journey starts when you step off of other qualified insurance and you turn on your A and your B. That allows you to choose one path over another. And a lot of people will start with the path of original Medicare, okay? We're going to talk about what A and B cover, and you'll get a very clear sense as to why you're going to need to piece in drug coverage and maybe piece in a supplement, also known as a Medigap plan. So that's option number one. And that option allows you to see any doctor anywhere in the US that accepts Medicare. It doesn't matter what insurance companies you buy these pieces with, the Part D or the supplement, your network is Medicare because the government's running your benefits. But if you go into the or choice, and it's an either or choice, one side or the other, and you choose Medicare Advantage, the first thing that's going to change for you is you're going to be in a managed care plan. So by design, that's going to be a PPO or an HMO or a fee-for-service plan, and you can choose from any of the flavors, shapes, and sizes that are offered in your county, okay? But these plans will include your benefits under Part A, Part B, and most of the time Part D. All right, so let's break down our foundational coverage. Let's understand that a little more clearly. Medicare Part A. As I mentioned before, this on your red, white, blue card says it's your hospital coverage. The important distinction here is that this is inpatient hospital care. Sometimes we go into the ER and they keep us overnight because they're not sure what's going on with us, right? But they don't admit us. That is called being under observation. And that would not bill to Medicare Part A. But let's say after 12 or 24 or 48 hours, they finally say, Robin, we know what's going on. We're going to move you upstairs to a comfy bed, and we're going to do this, this, and this, and you'll be out of here in 2 more days, okay? Well, upon admission, all my billing is now going to be directed to Medicare Part A. Maybe I have to go on after that hospital stay to a post-acute care center or rehab facility. I can't go home to recover. I got a hip and a knee done, right? And I got stairs in my house. I need some assistance. So I'm going to go on to skilled for a period of time until I can get my strength back and navigate around in my own home. Medicare Part A is going to have my back during that skilled nursing stay. Maybe I do skip skilled nursing. I can go right from hospital to home. I only had the knee done, and I can get around with a walker because I live in a ranch. So I can go home, but I need a nurse practitioner or a physical therapist or a physician's assistant coming to the house to help me. Maybe they need to change wound dressings, administer medications, do a handful of PT visits in the privacy of my own home until I can take myself to a facility. That would be considered home health, okay? Medically necessary, short-term in duration, a Medicare-approved provider, and your doctor generally orders that, okay? And hospice also is covered under Part A, whether it's end-of-life hospice or hospice that leads you back to palliative care, whether it's in your home or in a facility, it's a fully covered benefit under Part A. So as I mentioned before, Part A has no premium for most people because most of us have contributed into Social Security during our working years, so we've already paid for it. But it definitely has financial exposure, things that we're responsible to pay. And that looks like this in calendar year 2023. So the first night you are admitted to the hospital, Medicare is going to say, we got you, we're covering you, but you owe us a deductible of $1,600. And that triggers on night number 1 that you're admitted. Now it's a big number, but it covers you upon discharge up and through day 60. So why would that be important to know? Well, maybe you go into the hospital for an appendectomy and you're in and out in 3 days and everything's fine. But then you trip and fall on the sidewalk and you break your leg and you're back in the hospital in three weeks later. Well, you're still covered upon discharge up and through day 60. So you're not going to get charged $1,600 in that window twice, even if you have to go back in. But let's say you broke your leg and the appendectomy happened 6 or 7 months apart, right? You're probably going to get charged that twice in a year. All right. Now, we are certainly covered for longer than 60 days under admission. If something really went wrong and we were in the hospital 70 days or 80 days or 150 days, okay, Medicare would cover us. The next 30 days, days 61 through 90, bill at $400 a day. And then days 91 through 150, bill at $800 a day. That's what we have to pay. Skilled nursing, let's say we need to go on to rehab for a period. The first 20 days are going to be picked up by Medicare, but please note, I have a lot of points in the presentation tonight where I'm going to point out floating asterisks or half-truths or partial sentences that you might have heard in Medicare. Okay, these aren't there to trip you up, but they are things that you need to be aware of. This skilled nursing benefit, I put an asterisk by it because it does have a trigger. You need to be in the hospital under admission for 3 midnights for Medicare to pick up the first 20 days. So if you're in the hospital 4 days, 2 were under observation, 2 were under admission, and then you went on to skilled, Medicare wouldn't pay anything in that first 20-day window. That entire bill would be on you. All right. So you got to make sure that you are your own best advocate when you're in Medicare. If you're in a hospital situation and you know you're going to have to go on to rehab, you show that red, white, and blue card and you say, what are we doing? Why are we doing it? And who's paying for it? And what is my status? Especially if you know you're going to have to go on to continuing care after that. Now, let's say Medicare picked up that first 20 days because you did have 3 nights under admission preceding your stay, but you're there longer. Okay. Something bigger happened. You've got maybe 3 more weeks to go. Well, Medicare is going to cover you up and through day 100. The next 80 days are going to bill at $200 a day. That's going to be your out-of-pocket cost. Now, Medicare is not long-term care insurance. So when you get to the point of being in a skilled nursing situation for 100 days, on day 101, that's when Medicare is going to stop paying. And everything will be on you, okay, your cost. Maybe you have a long-term care insurance policy that you can invoke at that point, or some other insurance product, but Medicare is going to stop paying at 100 days. All right. If you go right from hospital to home, as I mentioned before, someone's coming to the house to do medically necessary things. It's going to be short-term in duration and a Medicare-approved provider, but it'll be fully covered by Medicare. And then hospice, to be fair, I put 5% to fill prescriptions that might keep you comfortable at end of life, but generally hospice is also a fully covered benefit under Part A. So this is more of a pay as these things incur type of benefit structure. All right. Medicare Part B is a different idea. This is where the lion's share of your bills are going to go when you're in Medicare. And as you notice, all the doctor services, surgeon services, blood panels or biopsies, which are your lab work, any EKGs, EEGs, MRIs, PET scans, CAT scans, that would all be diagnostic tests. Durable medical equipment could be walkers, wheelchairs, pacemakers, COPD machines, insulin pumps. Physical therapy, or like my clients like to call it, pain and torture, mental health therapy, occupational therapy, ambulance services, the ride to and from, the transport, anything that happens in the ER bills to Part B, all outpatient services. And this is a growing bucket of stuff. Okay. There are medical miracles happening every day in this country. If I had a nickel for every client who told me they had a full hip and knee replacement done on an outpatient basis, it would stun you. It's a big amount of billing happens on outpatient. Now, you could be in a hospital and have a procedure, but you're in and out in 5 hours, or you're overnight and they may never admit you. Okay. The entirety of that is going to bill to Part B. Or maybe you go to an ambulatory surgery center for a quick procedure and you're in and out in the same day. That also would bill as outpatient. Or maybe you went into the ER, right? And they kept you overnight because they weren't quite sure what was happening. But then the next morning they figured it out. They treated you, sent you home. They never admitted you. The entirety of that stay would bill as outpatient. Okay. And then clinical RX. This is the big stuff: chemotherapy, kidney dialysis, radiation therapy, any infusions, injections, radiation, chemo, any of that stuff. Even though it's pharmaceutical, it bills to the medical portion of your Medicare plan. All right. Now, Medicare has that premium of $164.90 per person per month graded for income, but it also has an annual deductible. That deductible this year is $226. If you're turning 65 and you're working and you're trying to decide, do I stay on my group insurance plan or do I go to Medicare? There's a lot of things to consider, particularly if you're taking along a spouse on that group insurance plan, right? And you don't want to necessarily have them lose that if you were to leave your job. But let's say you don't leave your job, or you're just trying to figure out, do I stay on that employer plan or go to Medicare? This is where Medicare becomes really powerful vis-a-vis some group insurance plans that I've seen, and I've seen a lot of them. It's really hard to beat that deductible, okay? Most group insurance plans have a couple $1,000s per person on a deductible. Now, maybe your Medicare costs are similar to what you pay out of your paycheck every couple of weeks for the insurance. But after that nominal deductible, Medicare is going to take their negotiated discount, call it that dash there, all right, which you're going to love because they take a pretty big discount. And then they're going to split bills with you 80-20. They're going to pay 80 cents on the dollar and you're going to be responsible for 20 cents on the dollar. Now, here's where things get a little concerning for people. This all sounds good. $164.90 a month, low deductible, 20% coinsurance. Okay. But here's the rub. Medicare is an unlimited benefit. That's the good news. They're never going to cap out what they pay on you in a lifetime. If you need the shoulder, the hip, the knee done, you get a heart transplant, you need kidney dialysis, they're going to pay for all that. But every time you're hospitalized, they're going to look to you for that $1,600. If you have to go on to skilled for longer than 20 days, the $200, and they're going to look for the 20% coinsurance on the doctor bills, the surgeon bills, the labs, tests, scans, x-rays, the PT you had after the surgery. And this 20%, as well as anything that bills to Part A, sky's the limit. There's no max out-of-pocket concept in Medicare. And that makes people nervous because it doesn't matter what kind of insurance you've had up until this point in your life, chances are it's always had a firewall, right? It's always had a max out-of-pocket concept. So if you had a bad year health-wise, you knew, even on the Affordable Care Act, there's a number, right? And if I hit that, I'm done paying. So this is kind of a new idea for most people, which is why we talk about Medicare being very good, but incomplete coverage, and coverage that you certainly want to get backup insurance to support you, particularly for 20%. Because 20% of an office visit or a blood panel, not so bad. But if you need some of this bigger stuff like clinical RX or you have an ER event, that could run up really fast. And I'm sure everybody in this room and people at home, a person, right, that had something happen in their life that was unexpected or unforeseen, and they rung up tens of thousands of dollars of bills pretty quickly. Hopefully they had insurance, but you're going to want backup for your 20% as well. So that's when we go back to our diagram of the paths we can travel in Medicare. Original Medicare, like I said, is where a lot of people begin, and they'll look at one of these Medigap plans to help cover some of that out-of-pocket costs that we just explained. Now, these plans are also sold by private insurance companies. So as an independent broker, I help people figure this stuff out at no cost to them. But Part D, Medicare supplements, and Part C Advantage plans, those are all private insurance products. If you go to the Social Security office and try to sign up for one of those, they're not going to help you. The only thing that's between you and the government is Part A and B. Okay, so all this other stuff, you're left to your own devices to figure out on your own, which is why I suggest a navigator. But the one thing that you should be aware of is that, Medicare has oversight on all this stuff, even though they let private insurance companies sell them to the public. Now, with the Medigap plans, also called Medicare supplements, two names for the exact same thing. They fill the gaps of what Medicare needs you to pay, or they supplement what Medicare requires you to pay. So their names are very indicative of what they do. But there are 10 plans defined by the federal government. Unfortunately, the government didn't give them names, they gave them letters. So when I refer to a part of Medicare, Part A, Part B, I'm talking about your foundational coverage. When I refer to a plan in Medicare, Plan A, Plan B, I'm talking about a Medigap plan, okay? Or a supplement plan. So there's 10 plans to choose from here, and they're sold by insurance companies. About 44 different companies in the state of Illinois sell these products, but the government says what each of them cover. So people always ask me, do you mean to tell me that, from one insurance company to another, this coverage is the same? Blue Cross, United Healthcare, Aetna, Cigna, Humana, whoever it is, they're all the same? No, they're identical. They're identical. What's different is the price, okay? They price the products differently. Many of these companies, there's a lot to choose from that have a longstanding track record in the business, are A-rated financially, have modest rate increases year over year, and really good prices. That's how we look at this and evaluate this landscape for our clients, okay? There's safety in numbers here. You want to be with companies that have been in this space for a while. There's a lot that haven't been, big names that that haven't been in the med supp space a very long time. And unfortunately, they probably have a risk pool of people that they're insuring that's about that big, right? So how these work is you join a risk pool of people that bought that plan from that insurance company. And the government says, that these insurers have to play by Medicare rules. All right. So rule number one, if I'm an insurance company and I want to sell a product like this to the public, I got to take you when you first come to Medicare. No questions about your health. You cannot be denied. You cannot be rated up for any health conditions. No pre-existing exclusions. I got to take you, right? And most carriers will price their prices based on attained age in Illinois. There's a couple that are community rated, but your supplement booklets that I gave you today, those explain how insurance companies initially set their prices. But the thing to know is whatever the price is set at initially, it's going to go up every year as you age, because the second rule that Medicare says is you, in addition to taking everybody when they first come without question, you also can never drop them unless they fail to pay their premium. So, if you have a bad year health-wise, they can't say you're a risky bet and drop you. But if you fail to pay your monthly cost, they'll drop you for that. They also can't single you out for a rate increase based on the claims that you file. So everybody's prices go up a little bit every year, because in that risk pool, that all those claims are being spread around, which is why you want big risk pools with large companies that have been in this business a long time. Now, there's 3 plans that have driven the market for years: the F, the G, and the N. Now, in January of 2020, Medicare passed legislation that turned off new enrollment for anybody becoming Medicare eligible after January 1st of 2020. So if you qualified for Medicare after that date, there's 3 plans on this chart that you cannot buy. You can't choose them. C as in Charlie, F as in Frank, and the high deductible version of F. So you can just scribble right through those on your chart. But if you look at these 3 plans, what you'll notice is that there's 100% in a lot of these columns. So that's why they're popular, because they cover the most things for you and they're easy to understand. If along this left-hand column here is everything that I just talked about in terms of your financial responsibility under Part A and B after Medicare pays, and you go across the columns and you see 100%, basically means that that supplement is going to wipe out those charges for you. All right. So if your eyes are drawn to the F plan, it's because F is going to pay everything. It's going to pay that $1,600 deductible. It's going to pay the $200 in skilled nursing that you're charged after day 20. It's going to pay the 20% coinsurance. Heck, it's even going to pay that Part B deductible of $226, right? Now, C and F are shut off to new enrollment. Medicare did that because they want everybody to have a first dollar in experience. They want everyone to be paying toward that deductible. So those plans were the only 2 that covered that deductible. But the other plans that are really similar to those 2 are the G and the N. G literally does everything F does. The only empty box that G has, and F paid for it, G doesn't pay for it, is the Part B deductible, $226. Okay. But I will tell you, for years, the F plan has been overpriced by insurance companies. They charge you way more than $226 a year for the convenience of paying the first $226 for you. The insurance industry is interesting. They will be happy to pay all your bills if you want them to, but the more extensive the coverage, the more expensive the coverage. So if you're willing to dig into your pocket and pay that nominal deductible, you might save $30, $40 a month in premium between those plans, maybe more. If you're willing to take on a deductible and the occasional copay for an office visit or an ER visit, then maybe a Plan N might be a better value for you. Plan N pays for all the big stuff the same way: hospital, skilled nursing, 20% coinsurance under Part B, has the same deductible as the G plan, $226. That's a Medicare deductible, not the insurance company deductible. But you could pay, Medicare says, up to no more than $20 for some office visits. That's at the bottom of the page. Or $50 if you go to the ER and you're in and out. You're not admitted. All right. So if you're willing to pick up deductibles and copays, your premiums might go down even further. Now, if all you want to do is put a firewall behind your Medicare benefits, okay, you just don't want to be responsible for an unlimited amount of out-of-pocket expenses, you could get the most Spartan coverage on this chart. And that would be the high deductible version of G. The high deductible version of G says, pay everything under Part A and B that you're responsible to pay, up to, but no more than $2,700 in calendar year 2023. And that's at the bottom. Now, we do see that deductible, that high deductible number go up a little bit every year, but it's not hundreds of dollars. It's more like tens of dollars that it goes up. But if you're willing to just put a firewall behind your Medicare benefits, your policy cost could be even lower. And remember, your Medicare bills go into two different directions, bucket A and bucket B, right? And after you pay off $226 under Part B, you're still going to get advantage of the 80-20 split. So this isn't everybody's cup of tea, that high deductible supplement. But what I want to illustrate to you is that you can get very robust coverage. You can get very Spartan coverage. You can get middle of the road coverage. Okay. You don't have to overbuy here. You don't have to underbuy. There's a ton of choices. We're going to take a rational assessment of our needs. We're going to look at companies that have been in this business for a long amount of time and have demonstrated a modest track record of rate increases over the years, okay? Because these will go up as you age, all right? But there's a lot to choose from. You can maybe get household discounts on these policies. Sometimes if you just live with your spouse, they don't even have to be in Medicare, you might get a discount. Other carriers sometimes want you both to have a supplement from their company. You don't necessarily have to have the same coverage. You could have the G, your wife could have the N, or vice versa, but you know, it's worth taking a look at wherever you can capture a discount. All right. But these plans, because they have nothing to do with Medicare and the US government or the federal Medicare program, they're private insurance products that you're buying to back up your Medicare benefits. They're not star rated by Medicare. Okay. They don't have that star rating that you'll see on Medicare.gov. Only drug plans and Advantage plans have that. All right, so now we've picked a supplement and we know that we can never be dropped unless we fail to pay our premium. These renew every month. They're month-to-month policies. They have to take me when I first come, right? And I can't ever be singled out for a rate increase based on the claims that I file. But let's say that I've watched my premiums go up and now I'm 75 and I'm paying more than I paid at 65. And so I want to shop around. Or maybe, knock on wood, you know, I'm doing pretty good. I still only see my primary care doctor once a year. I see a couple of specialists a few times a year. And I bought the G plan. Maybe I could throttle it back to the N plan and save some money. So I go searching again, right? That's fine. You can do this any month out of the year. It's not tied to this Medicare annual enrollment. But now I'm going to have to answer a certain set of health questions on the application. And the insurance company is going to pull my pharmacy report and my medical records. And one of three things is going to happen. Either I'll get the policy at the price that I'm quoted. The insurance company might say, you know what, Robin, over the last 10 years, you've developed a couple of chronic conditions with a few combinations of pharmaceuticals. And so you're a riskier bet. We're going to rate you up in price. Or they might just say, you have a pending cataract surgery. Thanks, but no thanks. We don't want to pay for that. And they'll flat out deny me coverage. Now, that window of opportunity that you have when you first come to Medicare, whether that's at age 65 or whether it's at 72 when you finally decide to retire and turn on your Part B, that's what triggers your open enrollment window to get one of these products without any medical underwriting. And that window lasts for 6 months before you activate B and 6 months after you activate B. And once it's over, it's over. Everybody gets it one time in their lifetime. Okay. Now we do have a blessing in Illinois. We have one insurance company out of 44 that if you were 100 years old and in a hospital bed and you needed to change your supplement, they would take you. Okay. They're not going to be the cheapest game in town, but they're going to give you a policy. And that's a very unique thing in Illinois. I don't think there's another state in the 50 that have an insurance company that doesn't medically underwrite you for Medigap plans. Okay. But we do here in Illinois. All right, so we've made a good choice on our Medicare supplement plan, but now we need prescription drug coverage, all right? And this is something that, as I mentioned before, you don't want to take a pass on when you first come to Medicare. Some people do. They say, well, why should I pay for a drug plan when I'm not taking anything? And I usually say, you're absolutely right, but the government doesn't want you to be out in the cold. If you do get prescribed something, they don't want you to be without drug coverage. And they want everybody contributing into the system. So they assess a late enrollment penalty for every month that you didn't have a drug plan, that you could have had a drug plan, and they just cumulatively add it up in the background until you finally decide you need a drug plan. And then they're going to lock you out and say, well, I'm sorry if you just got prescribed a very expensive medication and it's July. If you don't have a qualifying event that allows you to come into Medicare Part D for the first time because you've retired or you've just stepped off of other creditable drug coverage, you got to wait. You got to wait till the annual election period, which is October 15th to December 7th of every calendar year. So we'll accept your application for a drug plan at that time, but your benefits aren't going to start till January 1st. So I'm sorry that you were prescribed, Jardiance, which is $700 a month. You're going to end up paying $700 a month for Jardiance between July and December. And when you finally do have your drug plan go in force on January 1st, that penalty that's been cumulatively adding up for all the years that you didn't have a plan that you could have had a plan, they're going to add that on top of your premium every month in perpetuity for the rest of your life. So it's not a one-time penalty. Rule of the game is don't take a pass on Medicare Part D. Now, the good news is insurance companies have gotten wise. They know that you all are aging better than your parents. Okay, at 65, you're way healthier than they were at 55. And so they've come up with drug plans that this year we had 2 plans under $10 a month. Next year we have a 0 premium plan. So it's very cost effective for you to get your foot in the door. Now, on that 0 premium plan, when you go to fill your drugs at the pharmacy, you're going to pay something to fill your meds, but the insurance doesn't cost anything. Okay, so it's unwise to take a pass on this. Please know that these plans have different formularies, different menus of drugs that they cover. Okay, Medicare sets a master formulary of all the common prescription drugs that people take in Medicare, but every insurance company decides what subset of drugs on that formulary they're going to cover. And you might take the same drug as your spouse or your neighbor or your friend, but you might have 2 different drug plans, and those drugs might fall on 2 different tiers. Okay, maybe you take lisinopril and they take lisinopril, but on their drug plan, it's a tier 1, and on yours, it's a tier 2. And on their drug plan, tier 1 generics cost $2, and on your plan, they cost $3. That can happen. All right. So these aren't a one size fits all. Okay, they have different menus of drugs that they cover. Drugs can be tiered differently. There can be different costs by tier. Question.
Is the government watching the cost that these people are charging for drugs? I mean, you hear of people going to Canada because.
Yeah, it's a problem.
So, I mean, it's profit on these companies.
So here's the problem with Medicare Part D. It's a little bit broken. I'll give you that. The question was, is the government watching what's being charged? Not so much what you're paying at the pharmacy for drugs, but like the pharmaceutical industry really drives that, not so much your insurance plan. Okay. So what the drugs are being retailed for is becoming the problem. And the Inflation Reduction Act passed some legislation that isn't going to go into effect really until 2026 as it relates to capping costs on certain drugs. But what the government's finally starting to do is they're starting to negotiate with pharmaceutical industry, and they're going to segment out certain categories of drugs, like 10 at a time, in the years to come that will be capped. We saw this happen a couple of years ago with insulin, where they capped insulin at $35, and they're going to start to do it with some of the other pharmaceuticals. Now, it's important to understand that there's about 20% of the drugs out there that are costing the Medicare system about 80% of the cost. So Medicare Part D and the insurance companies that offer Part D plans can only do so much within the parameters of what prescription drugs are costing in this country. But that's part of the problem, which is why people are finding other resources to fill their medications. And I don't think there's anything wrong with using Good RX or Clever RX or Cost Plus Drugs or any of these wholesale discount coupons to fill your medications for less cost. Heck, go to Canada, go to Canadian Drugs Online if you want. Medicare, the government requires that you have a Part D drug plan. They don't require that you fill all of your drugs under your Part D plan. So you get your medications however it's most cost effective for you to get them. Okay, but let's talk about how Medicare Part D works. There are stages of coverage that is common to all Part D drug plans. This year we had 24 different drug plans available in the state of Illinois. Next year we have 22. All of those plans, or a good portion of them, I don't want to say all, probably 3/4 of all plans had a deductible. But how that deductible applied varied by insurance plan. So the ones that had a deductible, sometimes that deductible applied to drugs on all the tiers 1 through 5. Sometimes it only applied to the drugs on the higher tiers, the more expensive medications, tier 3 through 5. So what that means is if you have a drug that applies toward the deductible, you have to pay full retail for that drug until the deductible's paid off. This year, Medicare set the deductible at $505. Next year, it's going up to $545. While you're in that stage, you're going to pay toward the deductible, and then you're going to move to the initial stage of coverage where your plan is going to have all your drugs tiered, and there's going to be a certain cost by tier. Now, that cost might be a flat copay, $5, $10, $40, or it might be a percentage coinsurance, 18% of retail, 20% of retail, 50% of retail. So that's something that you need to pay attention to on the plan that you're choosing. Okay. But while you're in this initial stage of coverage, paying whatever copay or coinsurance is assigned by your plan, Medicare is tracking the retail value of the drugs that you're filling. So you might be filling $700 worth of drugs and you're paying $70 in cost out of your pocket in copays or coinsurance. And every time you pay your $70, Medicare's tracking the $700 that your drugs are worth. And they add up $700 plus $700 plus $700 until this year, if you hit $4,660 worth of drugs you filled, that's when they said, okay, time out. We're glad we were able to support you in this initial stage of coverage with copays, but now you're going to be in the coverage gap and you're going to pay 25% of retail across all of your medications. Now, for the drugs that you were paying $5 for, they might go up and, 25% of retail, they're going to go up in price. But maybe if you were paying 50% of retail, not a flat copay, they might go down in price. So it just depends. And then this threshold next year is going up to 5,030, I think. And then when you're in the donut hole, also called the coverage gap, they're tracking what you're paying as well as how the insurance is supporting you. So it's not like you're paying $7,400 out of your pocket before you get rate relief, but you are going to pay a decent amount. And next year, that $7,400 is going up to $8,000. And once you reach $8,000 in combination of what you've paid and how the insurance has supported you between the initial stage of coverage and the donut hole, then you're going to get catastrophic coverage rate relief. Now, here's what happens to the average person. They fall into the donut hole because they have 1 or 2 drugs on their list that are kind of spendy. Everything else are generics, right? And those 1 or 2 drugs, throw them into the donut hole about this time of year. Late August, September, October, but then they never get out of the donut hole to catastrophic coverage and get rate relief. Conversely, there are people that, fill one medication and it's a $15,000 med and they blow through all stages of coverage in the first 2 months of the year. And this idea is a godsend for them. Okay. But for the average person, it doesn't always work in their favor. So what we try to do when we're helping people pick drug plans is we're trying to optimize your lowest total out-of-pocket cost really between the deductible stage and the initial stage of coverage, because all the plans work the same once you get to the coverage gap. And so we look at that over a 12-month period or however many months you're going to be on the plan, the cost for the insurance plus the cost to fill your medications combined. And we kind of rank sort them least expensive to most expensive. And we try to pay attention to plans that are 3-star rated and above. There's a 5-star rating system on Medicare for these plans. Okay. So that's, you really, if you're taking certain medications that are going to throw you into the coverage gap, you can't avoid it, right? You got to take what you're going to take to stay well. But just know that you want to plan for this and prepare for it so you're not surprised at the pharmacy when that happens. Now, some people will, use these wholesale discount coupons and resources online to get some of their more expensive medications outside their plan. And if you're filling something outside your plan, just know that Medicare can't track the retail value of that drug toward your movement through the stages of coverage. So essentially, it's like it doesn't even exist as far as this is concerned. Okay. Now, this year, when people reached catastrophic coverage, their prices went down, way down. Nobody would pay any more than 5% of retail on their meds. Generally, generics cost about $4 and change. Brands cost $10 and change, but they would pay no more than 5% of retail. Next year, the one thing that is going to come through in and be enacted as part of the Inflation Reduction Act is catastrophic coverage amounts are going to go down to zero. So if you're one of those people that unfortunately gets here, fortunately or unfortunately, before the end of the year, you'll have no copays for your meds when you get to that stage. Next year, not this year.
I'm sorry, this seems like such a racket with the pharmaceutical companies.
I agree.
I mean, when we're looking at this, are they talking, is the government
Yes.
talking about saying?
Yes, they are. But here's the thing. It hasn't been the government that hasn't wanted to address this. I mean, there's two parties to that negotiation. There's the pharmaceutical industry and the government. So yes, we're finally starting to see some headway in that area. But until then, this is how Medicare Part D works, folks. Don't kill the messenger. Okay. But I feel for you, which is why we always talk about tweaking this annually during the annual enrollment. The government realizes that medications are a volatile piece of people's healthcare, right? You go on and off meds. Your doctor might try you on things for a period of time and then change it up. Brand names go generic all the time. So, what you've picked at age 65 and then stuck in a kitchen drawer and never looked at for 5 years, that's changed probably. And certainly if your meds haven't changed, the insurance company has changed things on you, right? So this is something to definitely look at during the annual enrollment if you haven't visited it in a while. So again, just know that your drugs will be tiered by whatever plan you're looking at, and the cost will go up as the tier goes up.
Besides the tier.
Medicare does. They initially, like I said, set a master formulary of all the common prescriptions people take in Medicare, and they'll assign a certain tier to that. But insurance companies can change that tiering structure. What you won't see is Medicare put a certain drug on a tier 1 and an insurance company throw it on a tier 4. But they might throw it on a tier 2. Okay. So that'll vary by plan. How do we figure this out? We go to Medicare.gov. Okay. And we go to this Find Health and Drug Plans tab. You can also call 1-800-Medicare and do this over the phone with somebody. We can help you out with it as well. But you plug in all your medications, the name, the dose, how often you take it, and you put in the pharmacy that you like to use. Are you flexible with your pharmacy? That's important because not every plan has the same preferred pharmacy partners. And if all you're looking for are in-network pharmacy partners, just realize that there's two types. There's preferred and standard. Preferred pharmacy partners in network are going to give you a lower cost to fill than standard. So on some plans, it's a negligible difference. On other plans, it's quite different. Mail order also is available, but it's not always the cheapest. All right. Retailers know that if they get you into the store every 30, 60, 90 days and you have to weave through the aisles, why do you think they put the pharmacy in the back of the store? Because on your way, you're going to pick up a box of cereal and a greeting card and some candy for Halloween. And they're going to make more money on that stuff than they do on the medications that you're getting from the pharmacy. So they like it when you come into the store. And they've made those prices very attractive for you to come in and pick things up, retail. But what we're going to look at when we run this analysis is, okay, I'm going to immediately look at this column, and I'm going to see that this person is filling $599 worth of medications. Now, this is a good plan for them because after they fill their Eliquis one time, they're going to get Eliquis for $47, which is a steal of a deal for a $500 drug. And these other ones, they're not going to pay anything for. They're Ventolin. Maybe we can switch that up to a generic albuterol inhaler and bring that cost down. But generally, after they pay off that deductible, which they're going to do in January, they're going to pay $77 for their $599 worth of meds. Okay. But the government's tracking that $599 number. So what that means is by August, this person is going to fall into the coverage gap, and their $77 that they pay at the pharmacy is going to jump to $149. All right. So we want them to be aware of that so they can budget for that and plan for that. Now, unfortunately, this person is going to fall into the gap in August. And as I mentioned earlier, they're not going to get to catastrophic coverage by the end of the year. So they'll be stuck in the gap until December 31st. And then on January 1st, everything will reset down to zero. All right. Please note that if you like a pharmacy, you want to make sure that it's preferred on your plan. All right. We always have a needs analysis conversation with our clients. And, we say, are you open to pharmacies? And, yeah, CVS is across the street and Jewel goes around the corner and Walgreens is next door. But they really like Walgreens because they have the drive-through, right? And we gave them a recommendation to use CVS, and then they start to go to fill their meds at Walgreens. And I say, hey, well, they call me and say, my meds are costing more than you told me they would. And I go, well, are you going to CVS? And they say, no, I'm going to Walgreens because I like it because they have the drive-through. Well, you got to be honest. We got to have conversations about this. If you really love Walgreens, we're only going to look at the 10 plans that love Walgreens. The rest of them, we're going to look at CVS or Julasco or wherever else is convenient. Okay. So now we've got one side of our path complete. Medicare A and B, really good, but not complete coverage. We've added our drug coverage specific to our medications, and we've chosen wisely on our Medigap plan. Not too much, not too little. We picked a good company, good track record in the business, good prices. And now we're paying, upwards of maybe $250 a month for these two things because we're in our 80s. And I'm still going to the doctor once. My spouse is going a couple times a year. And we think to ourselves, well, at $250 on me and $250 on you, that's $500 a month. That's $6,000 a year. We're not using that much of the healthcare system. Do we really still need access to any doctor anywhere in the U.S. that accepts Medicare? We're not traveling like we used to. We're not snowbirding like we used to. Maybe a Medicare Advantage plan would be a good option for us at that point. Or maybe we like that flexibility to see any doctor anywhere. We still go see kids and friends and neighbors all over the country. So maybe we just tweak this during the annual enrollment. We look to reapply for a Medicare supplement plan and bring our prices down. We look to tweak our drug coverage, and that's possible. Or we might look to Medicare Advantage. Now, I meet a lot of really healthy 65-year-olds who start in Medicare and say, listen, I try to avoid doctors at all costs. Now, maybe that's for good or for bad. They just aren't big healthcare consumers, and they would prefer to start here. A pay-as-you-go model, as I like to call it. Or maybe they are one of those individuals that has seen their supplement premiums and their drug plan premiums rise, and they're wondering how on a fixed budget they can get more economical about their healthcare. Medicare Advantage could be the answer, all right? The first misunderstanding people have about Part C plans is, I was told that they don't cover everything Medicare covers. That is a false statement. Okay, these insurance companies have done a handshake agreement with the federal government to take over for your care. By law, they have to give you everything Medicare gives you under Part A and under Part B. What they can do differently is charge you different costs for Medicare or for the benefits that they're giving you. Okay, you're still going to pay for your Part A and B. That money's going to be passed over here, and this insurance company, they might not charge you anything. You might see zero premium plans in the state of Illinois next year. We have a lot of them this year, PPOs and HMOs. Or you might see plans that are $20, $30, $40 a month, or maybe $80 or $90 or $150 a month. Okay, the pricing can vary. But at the end of the day, there's two things you want to know about Advantage. Number one, your network goes from any doctor anywhere in the U.S. that accepts Medicare to a PPO or an HMO. And if you're going to be in an HMO, just know that you're doing everything in one medical group. Why? Because you have to get referrals to specialists from your primary care doctor. And if you haven't noticed, we're lucky in Illinois. We have massive medical groups that pretty much have every specialty known to man in their practice. So if you're going to be on an HMO, that's fine. That can work beautifully for a lot of people, but that's what you're signing up for. All your care is at Advocate. All of it's at Northwestern. All of it's at North Shore. All of it's at University of Chicago. Okay, because your primary doctor in those practices are going to navigate you to the cardiologist, the endocrinologist, the dermatologist. Now, you might say to yourself, I don't want to have to get a referral. And in fact, I've already got a primary at Advocate, but I've got a cardiologist I love at Northwestern. Well, then a PPO plan would be better suited to your needs. And we can definitely find a PPO that's got, hopefully, your doctors in network on whatever plan you're looking at. Sometimes it's a harder fit if you've got a lot of doctors, but generally not. This year in Cook County alone, these plans are sold by county. We have 59 different Medicare Advantage plans. 59! That's a lot to choose from, which is why you all get so much mail. and you get advertised to incessantly this time of year. So what we're going to do is we're going to have a conversation about who are the doctors that are important to your care, because you don't want to change them at this point in life, right? So we want to make sure they're in network on whatever plan you're looking at. So that's going to be the first filter. 59 companies. Now, who's important to your care? We just whittled it down a little bit more. Now, do you want a PPO or an HMO? How do you like to move through the healthcare system? How do you like to live your life? That might narrow it down even further. Now we're going to look at what medications do you need filled? Okay, because different plans are going to have different formularies and cover your drugs at different costs. And then we're going to look at where can we minimize your max out-of-pocket cost? Where can we minimize your cost on a per service basis? Okay, because everything on these Advantage plans have a cost. If it's preventative care, generally no cost. Most of the plans this year had no deductible, no medical deductible. Some of them had a drug deductible. Okay, but instead of Medicare getting billed when you're over here and then your supplement just picking up the difference, over here, this insurance company is getting billed, okay? And they're going to decide what to charge you for a night in the hospital. Maybe $200-300 a night per night for the first 6 or 7 nights you're there. They're going to charge you for the specialist visit, $30-40 copay. You go to the ER, $90. You go to urgent care, $40. You get a blood panel, $20. You get an x-ray, $50. You get an MRI, $300. Everything's got an associated cost. And those costs count toward some max out-of-pocket number. So these plans do have capped exposure, which is nice. You have a firewall. You know if you have a bad year health-wise, you're going to be done paying if you ever hit that number. Okay, so just reminders when it comes to Medicare Advantage, Part C. You got to be enrolled in A and B because these plans are running those benefits. So if you're not signed up for them, you can't get them. These are private insurance products that replace Medicare. If you sign up for one of these plans, you're going to get an ID card that you show at the doctor, the hospital, pharmacy, everywhere. It's going to feel a lot like your employer insurance. You're never going to show your red, white, and blue Medicare card. As I mentioned before, these are sold by county. So you might know somebody in Tennessee, your cousin lives there, and they have a great plan from a wonderful insurance company. And you want to get that same plan here in Illinois. Chances are it doesn't exist. Maybe similar plans exist from that insurance company, but it's not going to be identical. And they may include some additional benefits. All right. Who heard the Joe Namath ads last year? Dental, vision, hearing, and more. You can get it all for no cost, right? All right. Here's the deal. Yes, sometimes these plans, because they're well funded by the federal government and they're for-profit businesses, they can add some extras. All right. These bells and whistles aren't core to what the government requires that these plans provide. So just be mindful that what you really want to make sure on these plans is that your doctors work, they're in network, your medications are covered, the cost structure under the plan works for you. Okay. Don't buy one of these plans for a bell and whistle. All right. Because that can be taken away the very next year. It's up to the insurance company. All right. You will have a more restrictive network than any doctor anywhere in the U.S. that accepts Medicare. Okay. You will now start to have to ask the question of providers. Are you participating in this plan or in this plan or this plan? But I would say check that ahead of time. Don't sign up for a plan unless you know your doctors are in network. You will have co-payments for things. All right. There's no secondary bill payer like there is in original Medicare with a supplement. This is your primary insurance. Okay. So your co-payments are going to be on you, but they'll count towards some capped exposure, some max out-of-pocket number. It's nice because your Part D is included in most of the plans, not always, but in most of the plans, Part D is included, so you don't have to pay for that extra. And then these plans can be changed without question, without consideration of your health every year during the annual election period. Okay. If you like it and you just want to let it roll over, keep on keeping on, right? I'm a big advocate of if it ain't broke, don't fix it. People go into a tizzy this time of year. Do I have to change my plans? No, everything in Medicare automatically renews. All right. But it certainly is a good time to ask yourself a few questions if you're on one side of the equation or the other. All right. Do you have any new doctors? Do you have any new medications? What is working well with your coverage? Or more importantly, what is not working well with your coverage? Is this still affordable? Do I want to shop these policies and try to bring costs down? Okay. This is your opportunity every year if you want to go from one side of the equation to the other, if you want to change up your Part D plans or your Part C plans, because those run on a calendar year, or maybe you just want to switch this up a little bit. Okay. But the choice is up to you. There's lots of flavors, shapes, and sizes. Don't go it alone. I could do my own taxes, but I don't because I'm always afraid of screwing it up. So I got a guy, right? I would never represent myself in court of law if I got into trouble. Similarly, I feel that way about Medicare. Okay. I've seen people make all kinds of mistakes on this journey, not because they intended to, but just because there's just a lot to figure out. And the government changes things on people. The insurance companies change things on people. So get a navigator. There's never a cost for our services. If you want to reach out to us, the library knows how to get a hold of us. We've got business cards here, but I'm happy to answer questions. We've got one here from the audience.
Are those shots covered under the basic plan, or do you have to have a supplement like COVID and flu?
Oh yeah, no vaccines. So there's a certain set of vaccines that are covered that expanded last year. So more of those shots are now covered under the preventative care under Medicare. So yes, yeah.
3-month thing you talked about earlier.
Mhm.
If your birthday was, your 65 was today.
Yes.
That means it was 3 months prior to today, or 3 is the first day of the month. That's 3 months.
So the soonest you can enroll in Medicare, your initial enrollment window opens up 3 full months before your 65th birthday month.
Does that mean the first day of the month or the actual day in that you turn 65?
No, it's the first day of the month. Yeah. So
Forward would be July 1st.
correct. Yes. Correct. So it's 3 months before your 65th birthday month, the month of your birthday, and 3 full months after your 65th birthday month. Correct. Right. Yep. Are there questions from the virtual audience? Sure.
Part A, does the 1,600 for hospital need to build Medicare? And if you meet the, or if you met the deductible and have co-insurance with 0 deductible, would you still owe the 1,600? So, does that make sense?
I'm not entirely sure what they're asking, but if Medicare is your prime, so the question was about Part A and specifically the deductible, and then what is billed after that. So if Medicare is your primary insurance, okay, that red, white, and blue card, and you're hospitalized, your financial responsibility, if you're admitted, is going to be $1,600 on the first night. Now, most people don't just have the red, white, and blue card. They have a supplement. And if you look at that Medigap chart, what you'll see is that almost all the plans, except for the high deductible supplement, cover that $1,600 at 100%. Okay. So if you would need that supplemental policy to cover that amount for you. Now, if you, let's say you worked for a small group employer, you had less than 20 people at your company, so you were required to turn on Part A and B at age 65. But you kept your employer group plan as secondary. You didn't buy a supplement. How that secondary coverage would support you for that 1,600 would be determined by what that group plan looked like. But that would be the only other coverage that maybe you would have as secondary to Medicare, a retiree benefit or some kind of group insurance benefit. Okay. That helps. Okay, great. Another question?
What's the difference between an Advantage plan and a Medigap plan?
So an Advantage plan, the question was, what's the difference between an Advantage plan and a Medigap plan? So Advantage, private insurance product that replaces Medicare, that runs your benefits in Medicare, that has a network that it's tied to, network of doctors, that will charge you copays for all services beyond your preventive care up to a max out of pocket. A supplement is a secondary bill payer to Medicare for your out-of-pocket expenses. Now, what supplements do not pay for is they don't pay for anything Medicare doesn't pay for, because Medicare is your primary insurance. So if Medicare declines a charge and says that's not a Medicare approved thing that you did, your supplement is not going to pay your portion. Supplements only pay your portion after Medicare pays their portion.
Well, okay, so Medicare comes in and the doctor is charging X amount of money, let's say $1,000.
Okay,
Medicare says this service is only worth $800,
sure,
that's what we're paying.
sure.
So the $200 is left over, is your responsibility?
No,
The Medigap?
no.
The Medigap?
So the question that was answered or asked was regarding physician charges. Okay. So if a provider bills $1,000 for something, okay, they're going to bill to Medicare Part B. And Medicare might say to that physician, we reimburse for that procedure or whatever they did at $800. Okay. So if you've paid off your $226 deductible, what Medicare is going to do with that bill is they're going to take that $800 and they're going to pay 80% of the $800. You're going to be responsible for 20% of the $800. All right. And if you have a Medigap plan that covers your 20%, your Medigap insurer, your supplement is going to pay that portion for you. Now, you might say to me, well, what about the $200 difference, right? The provider billed $1,000 and Medicare reimbursed at $800. The last article I read from a research study done it was done a while ago, but the article was published about a month ago, said that 98% of all doctors participating in Medicare accept what's called assignment, meaning they're taking the $800 and calling it a day. They're taking the majority of doctors that participate in Medicare, very high percentage. In Illinois, that percentage is actually even higher. This was a national average, right? 98% of all doctors are going to take the $800 as payment in full. Now, you might say, well, what if I go to the 2% that don't, right? What they're going to do is they're going to take the $800 as payment in full, and then they're going to say, I'm going to balance bill because I'm worth more than that. And Medicare will allow that balance bill charge to go through, but they will cap it at no more than 15% of what Medicare agreed to reimburse. So it'll be 15% of the $800, not the $1,000 and not the difference. Now, here's an important thing to know. You might have a Medigap plan, okay, that covers something called Part B excess charges. Now, Part B excess charges might not happen very much, that balance billing, because Medicare certainly doesn't address it on any supplements going forward except the G plan. But if you had a G supplement and your doctor decided that they wanted to balance bill above and beyond that $800, they could do that, 15% of the $800, and that balance bill would be paid by your supplement plan G. If you had any one of these other supplements, though, that responsibility would be yours. Does that answer your question?
I think, this
Okay.
is my second year on Medicare, and when I had surgery last year. And when I kept getting bills from them, like from the hospital.
Yes.
Here's what,
So
and then it's, you're not responsible for what's.
yes. So this is what you need to understand. When you're in the Medicare system, your explanation of benefits that you get after things, it's going to be pretty black and white. But what they're always going to show you is what the provider billed, what Medicare paid, what your supplement paid or what secondary bill paid, and what you owe. Okay. And that the you owe column, if you have one of these policies, could be minimized to very, very little. Okay. When you are on a Medicare Advantage plan, Medicare is not getting your bills if you're over here. Is that clear? A private insurance company is getting those bills. So these charges under Medicare A and B go out the window because the government isn't doing the billing. The private insurance company is. And you will find on your summary of benefit document, if you sign up for an Advantage plan, it'll tell you in black and white exactly what your charges are going to be. If you get an MRI, it's going to cost this. If you see a specialist, it's going to cost this. If you spend a night in the hospital, it's going to cost this. The beauty of the Medicare system is they require insurance companies to lay out everything in black and white for people in Medicare so they know what they're signing up for and they know what they're getting in advance. Okay. Now, what I can't tell you is what are you going to do health wise in a given calendar year if you're on this side of the chart, right? Maybe something big's going to happen, and maybe you'll hit your max out of pocket that year, or maybe you won't, right? So it is more of a pay as you go model. Over here, you're paying in advance for this policy to just be there to back you up.
Would you say it's important to ask the provider, do you balance bill before you?
You know what? It's better to just go on to Medicare.gov. So the question was, do you have to ask your provider if they balance bill? Well, if 98% of all doctors accept Medicare assignment, you're going to be asking a question of a lot of doctors that are going to say, no, I don't balance bill. But the quickest way to check, if you're concerned because you have a specialist and you're not sure if they're one of those folks, one of that 2%, you can go onto Medicare.gov. All right. And I'll show you on the website. Oops, I did something wrong here. Let's just go up to here. On the website on Medicare.gov, right on that main page, if you go down to the bottom below these little boxes, there are columns with clickable links. Everything's a clickable link. And one of the things is going to say find providers. If you click into that and then you navigate to find doctors, it'll ask you to type in a zip code and name, and it'll tell you right there if your doctor accepts assignment or balance bills or whatever. You know, the word it'll use is this doctor charges the Medicare approved amount, which means they're not balance billing. So that's where you can check any doctor. Rarely, but I mean, I'm sure they could. Generally, what they're doing is they're either saying, I'm not taking Medicare or I am taking Medicare. But again, majority of doctors do. Yeah. Any other questions from the virtual audience?
Still apply for Medicare if you do not.
Yes. So the question was, where do I apply for Medicare? If you navigate to anything on this page that says like get started with Medicare, if I click into that button, and then I navigate to, I want to sign up for the first time. Ultimately, this website is going to push me to the Social Security Administration website. The Social Security office, the Social Security website is where you sign up for Medicare A and or B, regardless if you're taking retirement benefits or not. Now, if you're not going to take retirement, you want to sign up for Medicare at 65, but you're not going to take retirement till 67 and a half to get your full benefit, that's fine. The Social Security office will send you a quarterly bill for your Part B premiums. And then when you do start taking your retirement benefit, they'll just automatically start deducting it monthly from your retirement benefit. So that conversion will happen for you. Okay. But you certainly can start here. Just know that if you click through the links to get started, it's ultimately going to push you to the Social Security website. And to use the online enrollment system, you have to either be coming to Medicare at age 65, or you have to have already signed up for your Part A, and now you're adding your Part B at a later date. And when you add that Part B, you're going to have to upload a specific form from your employer that says that you've had coverage since you turned 65, or your application will not be processed. So that second form must go with your Part B application if you defer. People who can't use the online system later are people that may be deferred on both Part A and B past age 65, because the system is going to require you to put in your Medicare ID to add the B if it's not your first time. Okay.
I'm going to end the virtual portion.
Okay. Thank you. Yes.
Are they ever going to be putting dental insurance into Medicare? Or is that eating dreamsicles on my part?
I think any kind of extra preventative care benefits is kind of a pie in the sky. You know, when you hear, because I don't know why. So you're covered for your eyes, ears, and teeth for illness and injury, but not prevention. So if you fall and knock out your front teeth, Medicare will pay for that dental work, but they're not going to pay for 2 teeth cleanings and you know, root canals and crowns that go bad. I mean, listen, the Medicare system is already underfunded. We still have between 10 and 12,000 baby boomers turning 65 every day in this country. We pay $164.90 per person per month. Now, certainly they ask the higher wage earners to pay more into the system, but it costs north of $900 per person per month to run our benefits in Medicare. So there's a big disparity, and that difference is made up with federal tax dollars, which is why two things are happening. There's a lot of, you can add these pieces. You can add separate dental, you can add separate vision, you can add, this idea that everything's in a package is what Medicare Advantage is going after, right? We'll give you some of that stuff. Come work, run your benefits through us instead of running them through the government. And many people are motivated by those extra benefits. But again, those products have to work for your doctors, your pharmacy, your budget. The extras are nice. They're not why I would buy one of those plans, because those plans can change year over year and the insurance companies can pull those benefits back. But you can always add that coverage on an individual basis to original Medicare. I don't ever see that kind of coverage coming out of the federal government plan. The system is not funded well enough to provide that kind of coverage for every American. They just aren't. I hope Medicare's around when I'm 65. I'm not far from it, but I hope it's still around and it doesn't cost a small fortune. It's a very underfunded system right now. Question in the back? Oh, of course. So again, cataract surgery is eye health, right? So you're going to be screened for glaucoma, cataracts, macular degeneration. They'll pay for your cataract surgery. They'll give you your glasses after cataract surgery. But if you wear multifocal lenses like I do and contacts, and I need a refraction exam every year, to get my new prescription, that's what they're not paying for. Okay. If I develop an illness or a disease that degrades my hearing and now I need hearing aids, they'll pay for that. But if I worked in a factory my whole life and my hearing is just shot, they're not paying for a hearing and balance exam and hearing aids. So that's kind of the difference. There's got to be some medical criteria that's requiring that some of that stuff gets covered and paid for.
Plans cover those things?
Yeah. Yeah. The Advantage plans do throw some of that extra stuff in. Hey, private insurance companies aren't stupid, right? They understand what Medicare is leaving you all open to have to pay for out of pocket. So these are the things that they're kind of adding to the mix to entice you to try them. But what you have to realize about that model of insurance is that it just works a little different than Medicare. Covers you for the same stuff, may cover you for some extra stuff, but the first thing they're going to do is they're going to narrow your access to care and they're going to charge you copays for everything. And if you're cool with that model, it can work beautifully for you. Okay. But don't just buy an Advantage plan for the dental benefit and expect to see any doctor that accepts Medicare and not have to get pre-authorizations and not have to pay copays. That is not going to work well for you. Okay. And honestly, it's different strokes for different folks. People always ask me, which is better? There is no better. It's what's right for you. Okay. Which is why if you work with us, we kind of sit down and we talk about your needs and what you want. I mean, there are a lot of couples I work with. The husband does one thing, the wife does something completely different because they're different people. They have different needs. All right. You don't have to be same anymore. You're not tied to the hip. In the employer world, you had to, you got two options, take it or leave it. Right. And regardless of your healthcare needs, you kind of had to opt into one or the other, but that's not how it is in Medicare. You can get very specific and design stuff around your needs.
I do have one more question that popped in that I wanted to.
Oh, sure. Yeah.
Do you need a different letter if you are
Cobra? So here's the thing about Cobra. You should not be hanging on to Cobra too long, max 8 months. But no, the employer form that is required to submit with Part B is actually available on Medicare.gov. You can email me. I can email it to you. But it's a specific Centers for Medicare and Medicaid form that the title of it is Proof of Employer Coverage. And so that coverage is going to represent your active work status coverage. So just make mind that if you're trying to come to Medicare past age 65 and you've hung on to Cobra for more than 8 months, you're not going to be able to enroll in Medicare when you're wanting to. You're going to be delayed until the first quarter of the calendar year, which is the open enrollment to sign up for your foundational coverage and benefits, and you may face a penalty for late enrollment. Okay. That's only if you're on Cobra and you hang on to it for beyond the relegated special enrollment period, which lasts 8 months from loss of employer coverage, or end of your active work status, whichever happened first. Okay. Any other questions?
This is a pseudo political question, but you talked about all the baby boomers.
Hmm?
There's more obviously now. Weren't all the baby boomers paying into the system and they were working
Oh, yeah.
decades and decades?
Yeah, yeah,
And there were fewer people on Medicare.
yeah, yeah.
Where's the money?
Where's the money?
Where's the
Well,
money go?
healthcare costs went up, my friend. So there's been a lot of money going into the system for years. Yeah. I mean, listen, there again, why does the US healthcare system cost so much? Why can people go to other countries and get procedures for so much less? I don't know the answer to that question, but what I know is we have a certain system that's very funded by a lot of hardworking people, and they expect that coverage to be there when they retire. It's there for them, but it's not complete. They have to have, other insurance to kind of help support them in that effort. And, it's not gonna, I wish it could cover all the extra stuff, but it doesn't. So, but I do hope that you all feel like for what you do get and what you pay when you start these benefits, it's a pretty good deal. I mean, compared to other options. I have friends that are on the Affordable Care Act, and it costs them $1,000 just to walk into an ER. They have crazy high deductibles and they're paying crazy high premiums per month. So this is a pretty good deal for, what you're paying and what you're getting. All right. Thanks, everybody. I think the library needs us to shut it down.